Hello, everybody. Welcome. Nice to be here. My name is Katie Leaf, and I'm the director for the Center for Health Literacy at UAMS. While I'm a bit newer to this role, I've been with CHL for almost 10 years now, serving in various capacities. And I'm honored to be here today to share my passion with you for clear health communication. Thanks so much for having me. So today we're going to talk about why clear health communication is important to your practice and roles in clinical care. And then I'm going to conclude the session with some tips on how you can improve your communication in your clinical practice with patients and families. So let's start off with the rationale for clear communication and how communication impacts your patients, your clinic, and ultimately all of you. So the importance of clear communication isn't just, it doesn't just happen during that patient encounter, like when you're face to face. Clear communication supports the patient throughout their entire journey, from their initial encounters with you in the clinic or on the phone, but also on our websites and other promotional content, whether it's social media or whatever, however they're deciding to make an appointment to seek out this care, to explore the services. And then also, obviously, through the clinical experience itself, appointment reminders, letters, all that stuff that even happens right before the visit, and then after. And this image, I borrowed it, but I added this important part of the journey that they hadn't included here in red, that self-care experience after they leave your clinic. And that's when those verbal instructions and then the written instructions and an after visit summary are really tested by your patients. It also happens to be the time when patients are responding to your satisfaction surveys. And I think their ability to take care of themselves must really influence how they respond to those questions. To put that patient journey in the context of the quadruple aim, let's start with patient experience, that light green section in the bottom right of this graphic. The communication touch points along the journey can really influence how people feel about the experience in your clinic. As that previous slide reminded us, this is more than just communication at the point of care. It's from, when they're just initially learning about you all the way to after they visited you and what's going to happen at home. And because communication is so important in these areas, it's measured in CAHPS surveys, specifically in the clinical and group survey by asking about how the provider explained things in an easy to understand manner. And while this is only one question, like I mentioned before, I can't help but think how like that whole patient journey might influence a patient's answers and how communication touch points really influence that experience in general. So when the experience that patient has is improved with empowering instructions and clear communication, this can absolutely lead to better outcomes on the individual patient and population health levels. If your patients have a better understanding of what your instructions are and what they need to do, then they're better able to engage in self-care. They're just better able to take care of themselves and manage their own health conditions. We also know that there are associations between those who have limited health literacy or those who are more likely to struggle with our health information and patient safety issues like medication errors. So when more people understand our instructions and how to take medicines, for example, then we can promote safety and therefore have better outcomes. And that's a win, right? And of course, we know that both patient outcomes and patient experience scores from those surveys that I previously mentioned can impact reimbursement from value-based reimbursement programs. And again, we have good evidence that limitations in health literacy are associated with less desirable use of preventative care and more than desirable use of those costly emergency room visits. And in fact, here in Arkansas, there are about 37 out of 100 adults, based on the most recent data, which is a little outdated, but it's the best we have, who have basic or below basic health literacy. And on the left, you can see those dark green shaded areas where the most people struggle with health information. And it's no coincidence that those are the very places where we see increased healthcare costs and burden of disease. You can see that the increased healthcare costs on the right side of this slide. There are also legal liability risks, that prohibit cost effectiveness in the medical setting, that are associated with poor health communication. And a survey conducted some time ago found that at least 4, maybe 5 out of the top 10 reasons for malpractice had to do with poor patient education or a breakdown in communication between the provider and the patient. It's estimated hundreds of millions of dollars are spent each year on legal fees associated with poor communication, and these impact the costs in that quadrant of the quadruple aim too. And then all of these factors, patient outcomes, how patients feel about their experiences to the care that we provide, the financial success of the system, the clinic where you work, they impact, I'm sure, how all of us feel about our work and how satisfied, you are with your job. And that's the last part of the quadruple aim that I want to talk about. And as I pointed out, when our communication fails, we aren't helping patients to improve or maintain their health. We aren't giving them good experiences in our clinic, and all of that negatively impacts our bottom line. And I would venture to guess that for many of you here, at least part of the reason why you got into this business was to help people and to make a positive impact. And if none of us are achieving, none of this can achieve that goal. So clear communication really helps us achieve that goal and enhances the quadruple aim. But let's be real. Communication can be really hard. It isn't just about putting your info out there. It is way more complex than that. So let's start with the transactional model of communication. You've probably seen this in any kind of like basic communication courses that you had back in undergrad. This model shows really the process that takes place when we communicate. This is depicted as an in-person, but it also really happens in written communication too. So, we exchange messages with someone or a group of people. The sender sends, the receiver receives it, they interpret that message, they take meaning out of it, and how they take meaning can depend on a lot of things. And sometimes there is noise, which isn't necessarily just the things you hear, but it's just interference in sending or receiving those messages. They're barriers, and they can include social, cultural, or relational factors that exist there. And included in that noise is personal health literacy. And so I want to get us all on the same page of when we talk about health literacy, how we defined it, what we mean. A lot of times people think about like health, it's health education, but it's more than that. It's a set of skills that somebody does or doesn't have that allow them to find and understand and use health information to improve their health. And so there's a lot of things that go into that, right? Like the healthcare system is complex. We have to navigate this. It just takes a lot of skills to find the information you need and internalize it, and then make decisions for your health and change your behaviors. A lot goes into that. So, and some of those skills are these here on the screen that our patients encounter regularly. Again, it's not just health knowledge. It's not about education necessarily. These are skills that people, have to be able to navigate the healthcare system and use information. First is prose or reading skills. So, we hand them, information to read. Can't read, then that kind of isn't useful to them. Document skills includes the being able to fill out forms. That's very prevalent in a clinical setting, I would guess. Every time you go in, you got to check some boxes and stuff. So, but if you can't read the form or you don't understand exactly what it's asking you, then that information isn't useful to the patient or to the provider who's trying to collect information from that. Quantitative skills, numbers everywhere in healthcare. I mean, how to dose medicine, how to read number on a thermometer, how to interpret your blood pressure, all of those things fall into quantitative skills. And then don't even get into like higher level things like interpreting risk and stuff like that. And then oral skills, so just chatting with somebody, being able to carry on a conversation, ask appropriate questions are skills that people need to have. And you've probably experienced people who don't know how to do that. And then digital skills, now more than ever, we expect patients to have skills to be able to navigate patient portals, use apps, use tracking devices. Those are all digital things. And some people don't have those skills that they need to be able to use them. And we make it harder sometimes when it's not, when we're not using plain language and clear communication. And this may or may not be a surprise to you, but only about 1 out of 10 adults in the United States have all the skills they need to understand health information. They have proficient health literacy to navigate the healthcare system and access information and make decisions appropriately for themselves. These folks, to give you some context, the folks in red who have basic and below basic skills, some of them cannot use a table with blood pressure readings on it to determine where their blood pressure fits in the scale. Some of them cannot use a map to find a location at a clinic. So those are pretty basic things, but those are the kind of things that some of your patients are struggling with. There are some groups who are more at risk for inadequate health literacy. They include underrepresented groups, people who have not attained like higher education, that have low income, and then adults over 65 in general are more at risk for inadequate health literacy. And just to break down that this underrepresented group, of those in the race category, I wanted to provide a little context so of your patient population who might be more likely to struggle. More than 5 out of 10, it's actually pretty close to 6 out of 10 African Americans struggle with health information. More than 6 out of 10 Spanish speakers struggle with health information. And then more than 3 out of 10, and this is a little bit more than the Caucasian white population, but more than 3 out of 10 Asian and Pacific Islanders struggle with health information. And the reason I included this is where our Marshallese population would fit in here. And while we don't have specifics on that group and what their health literacy status is, a lot would probably say it aligns even more with the Spanish-speaking population. But there's good news. There's a new definition of health literacy. This was established and really brought kind of more to the forefront by the Office of Disease Prevention and Health Promotion at DHHS in 2020 as a part of their Healthy People 2030 initiative. And this definition had been around for a while, but nobody had really focused it. We'd really put a lot of emphasis on this being a patient problem, but really it's our problem too, as health providers, as a health organization. and what we do to equitably enable people, our patients, to find, understand, and use information and services. We can make a difference in this and how we communicate with them. And that's what I'm going to talk a little bit about today. There's kind of two sides to this of the things that we can do to integrate health literacy into our clinics. We can either lower demands and expectations that we put on our patients, or we can increase our patient skills, increase the population skills. I think that kind of that two-sided approach is probably the best. I'm going to focus most of our time today on, lowering the demands and expectations and talking about using plain language best practices, and then teach back as a specific communication technique to use in the clinical setting. But then I'm also going to share some resources that we have available to actually increase patient skills. But before we dive into these, I want to mention that we should use these tips to lower demands on patients consistently. While we know who is more likely to have limited health literacy, you can't just look at somebody and tell if they don't, or if they do have adequate or inadequate health literacy. Because health literacy can really be a state condition, meaning that your current physical and mental states can influence your abilities to communicate effectively and take on information. I mean, just think about it. When you're sick or hurt or feel stressed, like you just don't think it's well, you can't take on that information. So even somebody who's well educated, who's worked in healthcare or anything like that, like me, I could still come into your clinic and I could still be upset or not feeling well and not be able to take on information as well. Even if I'm, considered to have adequate health literacy skills. So, and further, your patients may also hide their limited understanding because they feel shame or they're embarrassed about it. And they don't want to waste your time either. They might feel, oh, well, if I ask questions, it's going to waste their time. They don't want to do that. They respect you and don't want to put you in that kind of situation. So just as hand washing has become a universal precaution in infection control, it should also be assumed that every learner may have limited health literacy, or maybe just at the time struggling to understand. So we're going to start off talking about some plain language communication tips that you can use mostly in your verbal communication, because I figured that was probably what's most relevant to you. But what is plain language? You've probably heard of it. But to get on the same page again, this is information people understand the first time they see it or hear it. Plain language, it's readable. We typically aim to have our written material to be below the 7th grade level or less, anything that falls in this easy category. But readability isn't everything, and we're not going to be testing the readability of our verbal communication. So plain language is also understandable. You can make something easy to read, like you can put together a short sentence that maybe has a 3rd grade readability, but if it's not written or said in a way that makes sense to everyone, then your communication is lost. And then lastly, plain language is actionable. This tells people what to do, when to do it, how to do it, and sometimes where to do it, and maybe even why to do it, giving them all the information they need so they can act on what you're telling them to do. Okay, let's also talk about what plain language is not. I hear this all the time, unfortunately, and it hurts my feelings a little bit. It's not dumbing down or using baby talk. We work really hard to make sure that our communication resonates with a wide audience. That's really important because we do have different people that come into our clinics. And we don't want anybody to ever feel like that we're talking down to them or using baby talk. We want to resonate with all of our audiences. It's not writing less precisely. I'd almost say that 9 times out of 10, we're adding information to our content to make it more precise, to make it more understandable. We want to communicate that original message just in an easier way. It's also not attempting to be folksy or too informal. We use what we call living room language, but we never use slang or language that's too informal. And then we also are not leaving out unnecessary terms. People need to know these terms. They need to know about their diagnosis and, whatever it is, because they're going to encounter those words again. So we don't want to leave out necessary technical or legal terms in our plain language writing. So a big part of using plain language verbally is all about choosing familiar words. And I already mentioned this, but it's the living room language. But so how do you know, though, that they're familiar? Since most of my experience is really in written communication, I think about this a lot when I write and edit materials. I ask myself, how would I just say this if I was just talking to somebody, if I was talking to my mom or my husband or whatever? What are those words, that I hear all the time, that I hear people say in common, in their regular communication? Those are how I identify those familiar words. They're high frequency. They're things that we hear and read all the time. And I think about those things that I just casually say in the living room. That's why we call them living room language. So for example, we don't go to our coworkers and say, may I utilize your writing utensil? You don't say that, so why would we write something like that? Why would we say it in a formal way like that to a patient? You say, hey, can I use your pen? Talk to patients just like you talk to each other, using that common everyday language. Another part of those common words are choosing short words. So these are words that are less than 3 syllables. I have some examples here on the screen, but I'm always like checking my syllables when I write or when I talk to make sure we're using, the shortest word possible. So instead of additional, you can just say more. Contributing, instead of that, we can causes is shorter. Discussion, I need to say that, it's really long. It's also not common. You can just say talk. Gradually, you can say slowly or slow. Necessary, you can say needed. Obligatory, like nobody says that. You could just say have to. And instead of supplemental, you can say extra or added. I'm sure that there's lots of longer words that might be in your vocabulary, but I challenge you all to look for some shorter ones, some things that are 2 or 1 or 2 syllables only. And then this is one of my favorite tips, and maybe another common thing that kind of comes to mind when you think about or hear somebody say plain language. It's don't use jargon. And this jargon are terms that people that haven't been in the medical industry, they might not be familiar with, especially when you're maybe newer to a clinic. But it's not just limited to medical words that are scientific. There's also jargon that's prevalent in certain disciplines. So, for example, family medicine probably has some different jargon than the doctors and people in the Cancer Institute, right? And even on my team, we have some jargon that we use. And when we get a new person in, we have to orient them to our jargon. And when we're around people who aren't from our team, we make sure we try and avoid that jargon or define it for them, because when you're not a part of those certain groups, those other people aren't going to know what those words mean. Some common ones maybe in your setting include ambulatory. You'll notice that a lot of these too are multi-syllable. And so we just try and find those words that are shorter to go with them, to replace them with. So we could say walk-in instead. Additional, again, more. medical condition, health problem instead of medical condition. Instead of saying hygienic, we can say clean or wash. I'll say some of these might depend on the context and what you're talking about. Like it might not make sense to say clean your hands. It's more common to say wash your hands. But clean might be better in a different context. Instead of healthcare provider, we've heard from our focus group participants, we field test materials with community members who have failed a validated health literacy screener. And we've heard from them that that's not really a word that they're familiar with, and it seems very jargony and cold. So we tend to use doctor or nurse. Implement, and say begin or start. We always replace the term medications with medicine. You could use shorter words like drugs or pills, but those tend to have negative connotations. So we only use the term drugs if we're talking about illegal drugs. And then not all medicines come in pill form. So medicine seems to be more relevant. Musculoskeletal, I mean, I can't even hardly say that word. So sometimes we're, adding more words. So a good alternative to that would be about the muscles, bones, and joints in your body. Like sometimes it's not a one-for-one replacement. Prevalence, number of, but we'll talk about numbers in a little bit and why we maybe even don't need to talk about the prevalence. And then rapid or just say fast. Again, they're not always long. But we're just, again, looking for some common things too. But just like all the rules, there can be exceptions, and this is a good one. Sometimes you use jargony words that your patients need to know because they will hear them again, either from you or another provider, or even see them on a form. So we want them to know these words. They need to know what they mean so they can answer questions appropriately, or when somebody doesn't define it for them, know what they mean. So we want to define them, but we want to use a plain language definition for them. And like all things, don't assume that since you defined it the last time you visited with that patient that they'll remember what they mean the next time you see them 6 months, 1 year down the road. And as they say, repetition is the mother of learning. So every time you use certain words, you might want to define those. And those might include hypertension. That's a long word. If you don't have that health problem, then you might not know what it is. So give them a definition. Primary care provider, that seems pretty basic to I think most of us who are in healthcare, but some people might not know that that's like the main doctor you see for your health problems. So think about all those things and think about what you didn't know maybe before you started working at UAMS or in healthcare or whatever. And if you need help with these, there are some resources out there for you. Some plain language dictionaries. The top two here are my favorite. The MRCT Clinical Research Glossary. It has really nice definitions in there. I find myself being able to use those and not modifying them. It is very limited to research related though, so be mindful of that. And then the United Health Group, just plain clear glossary is my other favorite. It is very robust. It used to only really include health insurance type words, but they've really expanded it a lot into other terms, all kinds of diagnoses, health problems, etc. are in there. And the other great part about it is it's available in multiple languages, including Spanish, Portuguese, and I think Mandarin. Some of those might not be so relevant to our patients at UAMS, but that is available. And then some other ones are the Plain Language Dictionary from the University of Michigan Library and the CDC Everyday Words for Public Health Communication. So that Plain Language Medical Dictionary has a lot more medical terms in it, obviously, but it's very limited. It also hasn't been updated in a while, I don't think. So use that with caution. And then the everyday words for public health communication. It's, related to public health words, so that can be helpful. I think my word of caution for all of these is that think about your audience and what kind of words they know. I find in any of these a lot that I might kind of use these as a starting place and adjust the definitions as I see fit for whoever my audience is, because sometimes they're using like the word you're trying to define in the definition, and that's might not be helpful to the audience. So a few more things on word choice before we move on is you want to avoid words with more than one meaning. So that this, if we're using words that have more than one meaning, it can cause a lot of confusion, misunderstandings. You knew what you said, but the person you were talking to wasn't quite clear because you used a word that had multiple meanings. And for example, the board sanctioned the conduct. Well, that can mean that the board approved of or the board punished the conduct. It just kind of depends on what the context is. And if you don't give all the context, then somebody might not know. And then this is the next one is one of my favorites. The patient will be drained. Well, drained can mean, and probably means in this context, very tired, but some people might take that as like drained of fluid, and that's really scary. And we've actually seen this used in vaccine information, and there's enough vaccine hesitancy out there. We don't need to add to it. So just say the patient will be tired. And then we want to use those words consistently, like however you define hypertension or whatever your replacement is for the word healthcare provider. Use those terms consistently and don't swap back and forth, because that causes some confusion as well. It makes it harder to follow. So another tip on when we're providing instruction to people is we want to make sure that our words are actionable. It's important that you routinely emphasize 1 to 3 need to know or need to do concepts during your patient visits. You want to make it clear that there's an action to be taken, that you're not just presenting facts, you speak directly to the patient. For example, this is what I want you to do, make it clear and direct. Then it has to be clear that it is indeed the patient who you want to do it, not somebody else who needs to take action. For example, we need to get you signed up for WIC. Well, who's we in that context? Instead, saying you need to fill out these forms to get WIC. Or maybe if it's somebody completely different, the care coordinator is going to fill out these forms for you to get WIC. And then sometimes we need to provide more details to enable the patient to act. And we need to break those details down into step-by-step instructions. For example, record your blood pressure twice a week. Well, what if I record it twice on Monday? That could be interpreted that way. Or what if I do it on Monday and Tuesday? Does it need to be equal days apart? Does it need to be every 3 days? Instead, check your blood pressure on Mondays and Thursdays, and then write it in your log. These can really be, this works well really for written content, so the patient can refer back to it, but you can also supplement this as you go over it in a verbal encounter. So we've talked some about words and actionability, and I wanted to spend a little bit of time about verbally communicating numbers. There's a lot of tips around communicating numbers in written form, but there are some best practices when we communicate them verbally. And the first one of those is to avoid relative risk. Relative risk statistics are used to play on your emotions and persuade you one way or the other, and they can make communication unclear because it leaves out this compared to what information. So drinking 3 cups of coffee a day doubles your chances of a heart attack. That sounds really scary. It catches my attention, but what does it really mean? It leaves out some of the info that I need to make a decision. So instead of relative risk, we should use absolute risk. And from this table, you can see that the absolute risk is only 2 out of 100 when we drink coffee. Like I need to drink coffee every morning. And while it does double my chances, my risk for heart attack only increases by 1 percentage point, from 1 out of 100 to 2 out of 100. So if, these were real numbers, which I'm not sure they are, I think I'd take my risk of drinking my coffee, because while it does double my risk, it's not by a bunch. And it's no secret that most people don't like math. I am one of the weirdos that does like math, but a lot of people don't. And oftentimes I'll ask for a show of hands of people who do or don't like math, and not very many people raise their hands. And that's, I think, because people aren't good at math. It can be complicated. So when we can, we want to avoid making patients do math. This happens when we ask our patients, for example, to lose 10% of their body weight. Well, how much is that? Or how do I figure that out? A lot of people aren't sure. So if you can, like if it's not important, we would suggest just leaving out any of those kind of numbers or calculations altogether. But if the patient really does need to lose the weight and you have to mention it, then I would first suggest just doing the calculation for them. And just tell them, hey, you need to lose 15 pounds. But if there's an instance where they'll have to continually calculate something like tracking their carbs or something like that, then you should provide a detailed example. And that would be in like a written communication of how to do the calculation. You could even make a worksheet and break it down step by step for them. Or maybe it could even be the calculation could be provided in a table type situation. So up to this point, we've talked about how to improve your communication with some plain language tips. Now I want to focus on another thing that you can do to test your communication and assess understanding. You've maybe heard about this technique before, so this is just a quick review. Teachback is a communication technique that promotes understanding between healthcare providers and patients. It's a method of asking patients to repeat in their own words what they need to know or do in a very non-shaming, non-judgmental, non-blaming way. If it's done correctly, it can actually save time because the patient better understands what they're supposed to do. They're more likely to comply with, what you asked them to do and not come back to the clinic or call back the clinic because of misunderstandings, mistakes, or non-adherence. When clinicians think about, like when you think about adding like one more thing to your brief time of something to do with patients, I want to just say that this would take just like a minute to do Teachback. And if you think about the time that your patients aren't calling and asking for follow-up or scheduling other appointments because they misunderstood or don't know what to do, then that is, a net time saved. So I told you the main reason that we do Teachback is to assess understanding, but another great reason to do it is to also promote understanding. So we've all seen some version of this graph before, that when you, in the top, when you read something, you can only recall like 10% of it later. If we hear it, we recall 20% of it. But you skip down to that dark blue section, participating in a discussion, giving a talk. If we actually say something out loud, we remember 70% of it. So it's because it's much more active. And so that promotes, somebody's remembering of what you're being asked to do. And just in case you need a little bit more convincing about why this is a good idea, and how it's so effective and important, it turns out there's lots. So first is it enhances core concepts of patient and family-centered care, including information sharing that is useful and empowering, and engaging patients and families as participants in their care and decision-making. As you all know, and we've already touched on a few times, our reimbursement models are moving towards this focus on value. Think about value-based programs and that your practice participates in. It's likely that you're incentivized when patients avoid unnecessary use of the emergency department and when they attend preventative visits and schedule follow-ups after hospitalizations, et cetera. And many of these metrics are driven by patient behaviors. And if patients misunderstand the instructions and what they're supposed to do, then it's very unlikely that they'll uptake the behaviors that you're recommending. It also improves patient satisfaction as measured in CAHPS surveys, and it's evidence-based in that it improves patient outcomes as well. To name a few, there have been multiple studies on this, but just a few, it increased treatment adherence to patients with low health literacy who have type 2 diabetes. There's more information retention for heart failure patients, like they remembered all the things that they were supposed to do when they went home or when they were discharged. And then lower readmission rate also for heart failure patients. So that is a win. So I think if my video will play, I'm not sure it will. Oh, I think it's playing.
So, Mrs. Brown, you'll be going home with ibuprofen for your leg pain. Have you heard of this before? Kind of. Okay, the other name for it is Advil Motrin. How about that? Sounds familiar. Okay, this is to treat inflammation, fever, and in your case, pain. Some potential side effects are stomach pain, diarrhea, constipation, and ringing in the ears. Some urgent side effects are chest pain, shortness of breath, weakness, or bleeding or coughing up blood. Now, this is a medication card that I'll be giving you to take home. It'll have all this information on there. But for now, can you discuss what I've given you so far as if I was a family member and you were teaching me? Yes. Okay.
So I'm going to be going home with medication, ibuprofen, and this is going to be for my leg pain. And some side effects that I might feel is maybe upset stomach or vomiting. And if and when I feel chest pain or short of breath, that I should go to emergency room.
Right. So you're going to be taking, as you can see here, it says the dose 600 milligrams for pain as you need it. So if you
Okay, just cut that off. There's a little bit more, but just to unpack a few things, that was a pretty good example of how Teachback works. That was obviously in a hospital. I know y'all are working more in that clinical setting. This could be applied in multiple places in the clinical setting, including, you know, when you're scheduling appointments or billing can use this as well. A few great things they did. It was a good example, but we could have used some plain language better. The invite could have been a little better too. And so we're going to talk about how to execute this really quick. So the first thing you're going to do in this Teachback, using this Teachback method, is you're going to explain your concept. You're going to use plain language when you do it. And you want to try and focus on just a few messages at a time. We call this chunk, then check. So when you're explaining, you want to choose numbers and words wisely, use visual aids like they did in the video. That was really helpful. Frame your messages as actions, or remember giving them something that they need to do. And then limit that content to 3 or fewer concepts, and then you're actually going to invite them. And so, but how do we invite? This step is going to require some practice. It might seem like it might be like quite a habit to just ask, do you have any questions? Instead of doing this explicit invites, but that makes it so easy for patients to simply say, nope, I've got it. Again, they don't want to appear to be foolish or uneducated. And that, again, they value your time. And so they don't want to take up extra time, and they might even feel sorry for people waiting in the waiting room. But you must make it about you and not the patient. We're not asking what part of this do you understand or not understand. Instead, we're saying, I want to be sure that I explain this well. So being very explicit in that invite. I have some examples here on the next slide. So again, we want to avoid that habit of saying any questions. These examples, they put the responsibility on us as the communicators of like, I want to make sure that I did a good job, and they don't seem to test the patient, which is really important. There's also a clear invitation to do Teachback. Like, we can say, you know, that we want to make sure we did a good job, but unless we say, we need you to tell me in your own words, or please explain it back to me, unless you have kind of that explicit invitation, then they might not do it. I also want to caution you that, like I said, this takes a lot of practice, and when you first do it, there's probably going to be this awkward pause, because I don't think patients encounter this regularly. But just go with it, and the patient will respond, and it's going to get easier and easier as you practice. And then after you've invited and you've waited for that long, awkward pause, you're going to listen for the patient to repeat back the instructions. You want to listen for the key details and note any kind of gaps that they have in the misunderstanding. And then if there are misunderstandings, you're going to explain it again differently and ask for another teach back, and it might require multiple rounds. I want to note too that there are obviously some barriers to this, like there are noted barriers that people have on implementing teach back, and the first one is time, and I've already touched on that a little bit. But you got to consider that time that could be saved from limiting information and improving understanding. Like maybe your staff won't get as much callbacks. If you're really thinking about those 3 things that people need to know versus what's maybe nice to know, then maybe you're saving some time there. I'd also encourage you to start small and only initiate teach back at 1 time per visit. You know, maybe don't try and teach back everything, that all of your instructions, maybe just pick that most important one. As you get better at it, it's going to go faster. I'd also say that as you implement teach back, you're going to find those common places where maybe your teaching wasn't so good. It's going to help you improve your teaching and improve your communication. You're going to see trends like, well, people don't understand when I say this, so I'm going to say it a different way. And now when I say it that different way and they teach it back, they get it right every time. So it's going to get faster and faster. Also, like I mentioned, I know it will feel awkward. We do a whole 3-hour training on the teach back method, and people really struggle with that invite, and it feels awkward even when it's just us there. So I encourage you to plan ahead, practice your invite language. There's tons of resources out there about, you know, different invites you could use. Practice. You can practice in a mirror. You can find a buddy. And then some people just forget. So again, you want to plan ahead. You can make even a little script or a note card for like those common teaching, those common things that you teach with patients to help you remember. So we've talked a lot about what we can do to lower the demands that we place on patients. But what are we doing to help increase patient skills to navigate the healthcare system? So that's what this is all about. We have some tools that we've developed at the Center for Health Literacy to help improve patient skills. We have print materials and online resources. There's a couple of screenshots here of some of our print materials. So we have how to talk to your doctor and how to talk to your child's doctor. Those are used in primary care settings and help patients learn some tips to prepare for their doctor's visit. So the how to talk to your doctor uses your hand as a pneumatic tool to help them like remember everything they're supposed to bring and so forth. And then how to talk to your child's doctor uses the acronym STAR to get the right steps in, and both of those are available in English and Spanish. We have another handbook called How to Find Out About Your Health, and it gives a patient, again, used in a primary care setting, gives the patient some resources on how to learn about a new diagnosis. Some of the online resources we have is a new module on health insurance designed for young adults or people who are new to insurance to help them better understand it and use it to maintain and improve their health. And then we have some resources on emotional wellness, We have this How to Move Towards Emotional Wellness. It's available in print and online as well. And there's some links down there, some websites to look at those online on your own. So just as a summary, clear patient communication is essential for advancing the quadruple aim. You can use plain language and teach back to improve your own communication with your patients. And then there are also interventions that we have available at CHL and really probably beyond to enhance patient skills. That's all I have for today. I'm happy to take questions. Okay, so question regarding patients that can't use portals, apps, maps, that's an organization issue. What can UAMS practically do to improve this? I think from what I know about my chart, for example, there's kind of a limited amount of things that we can do to make, that portal better because we don't own all of it to make all the changes that, maybe a health literacy specialist might recommend. I will say that we work closely with the MyChart team and try to make sure that the things that we can change are reviewed for plain language. We are available, our team's available to review like any new apps that we do kind of have control over, or maps or whatever to make them more patient friendly. So we're happy to do that. Question, would Prinets help patients of what was discussed? That's a complicated question, I think. So our team actually manages the patient education materials for UAMS, and we have the UAMS patient education portal, and I'm a big fan of print materials. And I think that they can help supplement your teaching. But I do think that there is this potential, like we give somebody a big, pamphlet or a booklet or whatever, it's likely to end up in the trash or sit in their car for forever or whatever. And that's certainly not what we want. So I think you have to kind of balance that a little bit of like focusing those printouts on like the real important messages that you want to convey and making it really easy to find. And again, our team is available to help with that, and we manage the patient education materials at UAMS. Next question is, how would we schedule a teach back session? Well, you can email me. My email address is kjleath, Leath, at uams.edu. You can find me in Global. You can also visit our website. Our contact information is up there. I'd be happy to chat with you about that. Any other questions? I'd also invite you to stay connected. So here's our general email address, healthliteracy@uams.edu. So that'll get you somebody on our team. If you scan that QR code on the screen, it'll take you to a link to sign up for our blog. We send out like a monthly blog on plain language tips and health literacy best practices. And I guess if there are no other questions, then that is it. Thank y'all.